So now we'll do a quick recap of the topic. So we were just discussing the abnormal urine constituents. The normal healthy individual, the urine sample contains small number of cells and as well as the formed elements. And our point of interest is mainly upon discussion on the abnormal constituents. First and foremost, like we were discussing about the proteins. So what is the normal total quantity of the proteinuria? Right, so the total quantity of the proteinuria, so that is nearly around less than 150 milligrams per 24 hours, or if it is normal albuminuria, it is less than 30 milligrams per 24 hours. Okay, one point what I want to tell you here, add on point is, I said you by the urine dipstick test. I'll just add this at this point here. Yeah, so the urine dipstick test will detect the or will quantify the proteinuria. But one point you should understand is that the urine dipstick test will detect or identify only negatively charged proteins. Right, will detect or identify only negatively charged proteins. Right, it will not detect the positively charged proteins. Like example for the negatively charged protein, it is the albumin. The negatively charged protein is the albumin. Now, the other point that you should remember or understand is that you take in multiple myeloma, you are having proteinuria, right? In case of multiple myeloma, even though there is presence of large quantity of urine, that is nearly around 8 to 10 grams per 24 hours, in multiple myeloma, the urine dipstick test will be negative. Can anyone tell me why? Right, the urine dipstick test will be negative in case of multiple myeloma. Can anyone tell me why? Very good, Jacob. So in case of multiple myeloma, that light chains, they are positively charged. Right, light chains are positively charged. So that is the reason why the urine test will be negative. That is the false negative. Okay, because the urine dipstick test cannot identify the positively charged proteins. Right, so that is about the proteinuria story. So how much is the normal total proteinuria we have discussed? Less than 150, and normal albuminuria is less than 30. Right, and in the recent times what we are using is albumin excretion rate. And how do you calculate that? Urine albumin to that of the urine creatinine ratio, and it is expressed as milligram per gram of the urinary creatinine excretion. And when do we use the word moderately increased albuminuria? So moderately increased albuminuria is that when the quantity of the protein is nearly around 30 to 300 milligrams per grams of the creatinine being excreted. Moderately increased albuminuria, you have that in diabetic nephropathy, hypertension, and glomerulonephritis. And what do you understand by the word severely increased albuminuria? When the albumin excretion rate is around 300 to 3500 milligrams per grams, then we call it as severely increased albuminuria. And these patients with severely increased albuminuria, right, they are at increased risk of the cardiovascular mortality, right? And the conditions are diabetes, hypertension, then glomerulonephritis, multiple myeloma, congestive heart failure, fever, exercise, and orthostatic proteinuria. You will have markedly increased or severely increased albuminuria. Then overload proteinuria, you have that in multiple myeloma, rhabdomyolysis, and hemoglobinuria. Functional proteinuria, you have a person doing jogging or exercise. Nephrotic range proteinuria is that where the albumin excretion rate is more than 3500 milligrams. Causes will be diabetes, amyloidosis, minimal change disease, focal segmental glomerulosclerosis, and membranous glomerulonephritis. So how will you differentiate the foam or the froth which is there on the surface of the urine sample, whether it is protein or whether it is a normal urine? So how will you differentiate that? So you make the urine sample to stand for 5 minutes, and if that froth or foam disappears, that is the normal urine. But if the froth or foam, if it is present even after 5 minutes or even after 15 minutes, then you should consider it as the significant quantity of proteinuria which is occurring. And the next is the urine turns yellow in color on exposure to air. That is due to the presence of the urochromes. And when the urine dipstick is showing 1 plus proteinuria, the quantity of the protein is like 30 to 100. But if it is 15 to 30 milligrams per deciliter, then the dipstick test is considered to be trace. And if it is 2 plus, then it is considered the dipstick test, if it is 2 plus proteinuria, right, 100 to 300 milligrams per deciliter. And if it is 3 plus proteinuria, 300 to 1000 milligrams per deciliter. And if it is 4 plus, more than 1 gram protein will be there within the urine. Okay. Then we were discussing about the differences between glomerular and tubular proteinuria. Glomerular proteinuria, the pathophysiology in the glomerulus. Tubular proteinuria, the pathology is in the tubule itself. And daily excretion, if you observe, in glomerular proteinuria, it is more than 3 to 3.5 grams per day. Whereas in tubular proteinuria, it is up to 2 grams per day. The protein type in glomerular proteinuria is albumin. In tubular proteinuria, it is like beta-2 microglobulin. Then you have Tam-Horsfall protein and some enzymes. And we were discussing about the ratio, albumin to your beta-2 microglobulin ratio. In glomerular proteinuria, ratio is around 1000:1, whereas in tubular proteinuria, it is around 10:1. And Tam-Horsfall proteins are present in tubular proteinuria, but not in case of glomerular proteinuria. So this was the story related to the protein. And I said you like albumin is the predominant protein which is excreted. Then you should know about the cast. What exactly is the cast? Cast is nothing but it is formed via precipitation of the Tam-Horsfall mucoprotein along with any of the constituent, either with RBC, WBC or anything. And sometimes the cast may also contain the albumin. And where is this cast formed? Cast is formed in the DCT and as well as collecting duct. And if there is cast in the urine, think of the pathology in the kidney. In RBC cast, you have that in glomerulonephritis. WBC cast, you have that in pyelonephritis and interstitial nephritis. Pigmented cast, you have that in myoglobinuria and hemoglobinuria and acute tubular necrosis. Granular cast, you have that in acute tubular necrosis. Then in the normal individual, there can be presence of the cast, that is a hyaline cast. Muddy brown casts are seen in acute tubular necrosis. Broad cast is seen in diabetic nephropathy. Granular waxy cast is seen in chronic glomerulonephritis. Okay. And then followed by that, you need to know about the RBC. The number of RBC that can be there in the urine sample is less than 3 per high power field. And if it is more than 3, it is suggestive of microscopic hematuria. And if it is like 5, more than 5 RBC per high power field, and that is there in 3 urine samples and 3 different weeks, then it is considered as significant hematuria or persistent hematuria. But if the quantity of the RBC per high power field is more than 100 in a single sample, then also we consider it as significant or persistent hematuria. And dysmorphic RBCs, if they are there in the urine sample, you should think of pathology in the glomerulus. And your low power field is or low power microscopy or low power field is used mainly to detect the cast, whereas high power field is used to detect the individual cells, that is RBCs and as well as the WBCs. And what is the most common cause of gross hematuria? That is urological condition, that is ureteric calculi or bladder calculi. And most common glomerular pathology causing gross hematuria will be IgA nephropathy. And what are the causes of red urine? Clofazimine and as well as porphyrins. And if the urine dipstick test is positive for the RBC, then you need to do centrifugation for almost like 1500 rotations per minute for nearly around 5 minutes. If the supernatant becomes clear upon centrifugation, think of hematuria. If the supernatant is red, then it is myoglobinuria or hemoglobinuria. Wait for 3 hours. If the test tube becomes cleared, then it is myoglobinuria. If the test tube is still red, then it is telling us, along with hematuria, if there is pyuria or there is bacteriuria, it is suggestive of urinary tract infection. Along with hematuria, if there is presence of RBC cast or dysmorphic RBC, along with proteinuria is there, think of glomerulonephritis. Then we have what is called Katayama fever, that is in Schistosoma hematobium, where the individual will have hematuria, fever, and along with that, eosinophils will be there within the urine. And on urine examination, if you observe the egg, right, what will be the shape of this particular egg? Egg has the terminal spine. Okay. Then next is the presence of eosinophils in the urine. You observe that in atheroembolic kidney disease and allergic interstitial nephritis. Presence of the oval fat bodies in the urine, you see that in nephrotic syndrome, fat embolism syndrome, and then chyluria. Then what are the conditions where you have the Maltese cross? Maltese cross in the urine sample, you see that in nephrotic syndrome, Fabry's. Peripheral smear, Maltese cross, Babesia infection. CSF analysis, Maltese cross, cryptococcal meningitis. Then lastly, we were discussing about the color of the urine. Pink colored urine, you have that in deferoxamine. Pink diaper sign caused by Serratia marcescens. Then red urine, you have that in clofazimine or porphyrins. Cola colored urine, hematuria. Black colored urine, hemoglobinuria. Exposure of air, the urine turns black, alkaptonuria. Okay, right. Yeah, yes, Jacob. So apoprotein and as well as beta 2 microglobulins. Yeah, they are smaller than albumin, you're right. And then they are positively charged. Then only they can get filtered, right? If they are negatively charged, how can they be filtered? They cannot be filtered. Okay, and they are smaller than albumin. And this apoprotein and beta 2 microglobulins, they have to be absorbed by the tubules. If they're not getting absorbed by the tubules, then there is some pathology in the tubule, and that we call it as the tubular proteinuria. Right? Now, next important point in the urine, that is two important things that you should know. That is specific gravity, urine osmolality, and then the urinary pH. And then urinary pH. So, if you take the specific gravity of the urine, how much is that? And how much is the urine osmolality? Then how much is the urinary pH? Right? So if you see this, the normal specific gravity of the urine, it is around 1.020 to 1.030. That is the normal specific gravity of the urine. And okay, what is the purpose or what is the importance of the specific gravity? The importance of the specific gravity is this is used to differentiate pre-renal from intrinsic renal. I will discuss that, right, when I am discussing pre-renal and intrinsic renal type of acute kidney injury. So to differentiate pre-renal from intrinsic renal, right, the assessment of the specific gravity is very, very important. Then coming to the urine osmolality. So urine osmolality, various books gives various values, right? But just remember the value is 300 to 1000 milliosmoles, right? It keeps on fluctuating between these two, 300 to 1000 milliosmoles. Both the specific gravity and urine osmolality, both of it will tell you about the solute concentration. It tells you about the solute concentration. Then we have another terminology called isostenuria. Okay, what is isostenuria? Isostenuria means where the individual is having the excretion of the urine and the specific gravity of the urine is equivalent to that of the specific gravity of the plasma. That is called isostenuria. The word iso means same. The word iso means same. Stenuria, right? That is the concentration. So specific gravity of the urine is equivalent to that of the specific gravity of the plasma is called isostenuria. So where do you have this isostenuria? You have this isostenuria in chronic tubulointerstitial disease. And you have this even in cases of what is that condition where you or which hematological condition where you can have clumping of the RBC causing the organ infarction? What is the hematological condition where you have clumping of the RBC causing the organ infarction? Any one of you? Very good. That is the sickle cell anemia. Okay. So the other condition where you can have the isostenuria is sickle cell anemia. Here also you have the isostenuria. Right. So these are the two conditions where you will have the presence of the isostenuria. Then coming to the urinary pH. How much is the urinary pH is? The urinary pH always it fluctuates. And how much is the fluctuation? That is in between 4.5 to 8 is the normal urine pH. But what is that condition where you have the urine pH being more than 5.5 and it is fixed there? Normally it is fluctuating between 4.5 to 8. But one scenario where the urinary pH becomes more than 1.5 and it remains more than 5.5, it will not reduce at all. And you get that in cases of renal tubular acidosis. Okay, so renal tubular acidosis, we will be discussing that in detail. Right? So this is about the story of the specific gravity of the urine, urine osmolality, and as well as the urinary pH. Right? So this finishes completely about your urine analysis. Right? So with this, we'll wind up this particular topic of urine analysis and we'll move on to the next topic now. The next topic, as I have said you, that is renal pathologies. That is acute kidney injury, chronic renal failure. Then we have that the other conditions like nephrotic syndrome, nephritic syndrome, polycystic kidney disease. Just give me a quick information. Polycystic kidney disease, is it discussed in your surgery? So if you see this acute kidney injury, there are many definitions of acute kidney injury, right? But it is mainly defined with appropriate definition in KDIGO guidelines. I'll tell you what are the various definitions of the acute kidney injury. Acute kidney injury, it is defined by KDIGO, right? What does this KDIGO stands for? Kidney disease, improving global outcome. It is also defined by acute kidney injury network criteria, and it is also defined by Rifle criteria. Right? It is also defined by the Rifle criteria. Now, if you take the acute kidney injury, let me discuss the definition according to your KDIGO. So what did I tell you about the KDIGO as? That is kidney disease improving global outcome. Okay, so this is what is called KDIGO. Now, this KDIGO, it is a most recent and preferred definition, right? Now, according to KDIGO, what is the definition is, KDIGO has taken two parameters for defining the acute kidney injury. What is the important function of the kidney? That is urination. Another important function of the kidney is to excrete nitrogenous waste products. So now once the kidney is damaged, there will be excessive accumulation of nitrogenous waste products in the body, and along with that, the urine output reduces. Along with that, the urine output reduces. So according to your KDIGO, how much should be increase in the serum creatinine? The serum creatinine should be increased by, okay, does anyone know the normal value of the serum creatinine? normal value of the serum creatinine. Yeah, it is around 0.8 to 1.2. Right, 0.8 to 1.2. And based on the serum creatinine, the definition of the KDIGO was given. That is, increase in serum creatinine by more than 0.3 milligrams per deciliter within 48 hours. Right, increase in serum creatinine by more than 0.3 milligrams per deciliter within 48 hours from the baseline value. Like for example, yesterday's patient creatinine was 1.2. Tomorrow, the next day the patient has tested the creatinine, it is 1.5. That is suggestive of the acute kidney injury, right? Or there should be increase in serum creatinine value, right? There should be increase in serum creatinine value to 1.5 times the baseline, right? 1.5 times the baseline within 7 days. Okay, so increase in serum creatinine to more than or equal to 1.5 times the baseline, right? Within the prior 7 days. That is what is the definition of acute kidney injury based on the creatinine. Okay, can anyone tell me how much is the normal urine output in ml per kg per hour? Yes, normal urine output in ml per kg per hour. Any one of you? Yeah, it is 1 ml. Okay, yes, Jacob, it is 1 ml per kg per hour. It is a normal urine output. Whereas you take in acute kidney injury, what will happen to the urine volume? The urine volume will be decreased. Okay, urine volume will be decreased in case of the acute kidney injury. And how much will be that urine volume being reduced? That is less than 0.5 ml per kg per hour, right, for 6 hours. Okay, so that will be the urine volume in case of acute kidney injury. So these are the two things in the KDIGO guidelines. Now, what is the importance of your acute kidney injury network criteria? According to your acute kidney injury network criteria, so acute right, if you take the acute kidney injury network criteria, just 1 minute. Right, so according to this acute kidney injury network criteria, we have totally 3 stages. And what are the parameters taken into consideration? The parameters taken into consideration are, so we have 3 stages, 1, 2, and 3. Then serum creatinine concentration has been taken into criteria, that is staging. Then what is the quantity of the urine output is taken into consideration in the staging. Now, the serum creatinine in stage 1, it should be increased 1.5 to 2 folds. If you take the urine output will be less than 0.5 ml per kg per hour for nearly around 6 hours. Right, for nearly around 6 hours. Whereas in stage 2, definitely the increase in creatinine will be more. So this is like 1.5 to 2 folds is in stage 1, whereas in stage 2 it is increased to 2 to 3 folds. Whereas urine output, if you see, it will be less than 0.5 ml per kg per hour for nearly around 12 hours, right? For nearly around 12 hours. That is the urine output. Whereas in stage 3, the creatinine is increased. How much? It is more than 3 folds, right? And the urine output, it is less than 0.3 ml per kg per hour for nearly around 24 hours. Okay, so this is about the staging of acute kidney injury, right? That is based on the serum creatinine criteria and based on the urine output criteria. Now, what all we have discussed? Acute kidney injury, then KDO. Next is the rifle. Now, what has been added in the rifle? In acute kidney injury, staging has been done 1, 2, 3. Whereas in rifle, what has been added is the GFR component has been added along with serum creatinine, along with the urine output. GFR component has been added in the rifle criteria for acute renal damage. So, what does this rifle stands for? I'll tell you. This is your rifle criteria for acute renal damage. The word R stands for risk, right? And when will you consider it as risk? That is, there should be increase in serum creatinine. How many times? 1.5 times, right? Or there should be decrease in the GFR. How much should be that decrease in the GFR? More than 25%. And the next important thing in the risk is like urinary obstruction. So one is your GFR component has to be taken. Next is urinary obstruction. How much should be that urine output in risk? That should be less than 0.5 ml per kg per hour for nearly around 6 hours. Right, for nearly around 6 hours. That should be decrease in the urine output. So this value is what? This value is almost similar to that of your stage 1 of acute kidney injury network criteria. Right, there is no much point difference here. And even the serum creatinine which is increased, it is like 1.5 folds. But what do you mean by this word I? The word I is injury, right? So when you call it as the injury, that is, there should be increase in serum creatinine. How many times? That is almost like 2 times, right? That is almost like 2 times, right? Or there should be also decrease in the glomerular filtration rate. What percentage the decrease in GFR should be there? More than 50% the GFR has to be reduced. And along with the increase in creatinine and decrease in the GFR, the urine output also should be reduced, similar to that of stage 2 of acute kidney injury. How much is that? Less than 0.5 ml per kg per hour for nearly around 12 hours. That is injury. Then followed by that, we use the terminology called failure. When do we use this term failure? That is, there should be increase in serum creatinine. How many times it has to be increased? Almost 3 times. And at the same time, GFR also should be reduced. So in risk you take, it is reduced by 25%. Whereas injury you take, it is reduced by 50%. Whereas in failure, the GFR has to be reduced more than 75%. And urine output is similar to that of the urine output of stage 3 of acute kidney injury. How much is that? That is less than 0.3 ml per kg per hour for nearly around 24 hours. Okay, so that is what is your failure. Then you should know what all we have discussed: risk, injury, failure. Then we have L and as well as E. L is loss of kidney function, right? Loss of kidney function where there is complete loss of right, where there is complete loss of kidney function for more than 4 weeks. That is nothing but loss of kidney function. Then we have end stage kidney disease. Right, so when do we call end stage kidney disease? When there is complete loss of kidney function right, for how many days? For more than 3 months. Okay, so that is what is nothing but end stage kidney disease. Loss of kidney function, that is complete loss of kidney function for more than 4 weeks. End stage kidney disease where there is complete loss of kidney function for more than 3 months. So this is what is the description of acute kidney injury based on Reifel criteria. That is risk, injury, failure, loss of kidney function, and end stage kidney disease. Then, how do we classify the etiologies of the acute kidney injury? We classify the etiologies of acute kidney injury as the following. Right, you see this. The entire genitourinary system, right, it is in the following manner. You see here. Does anyone know what percentage of the cardiac output goes to the kidney? Anyone? What percentage of the cardiac output goes to the kidney? Very good. So that is 20%. That is 20%. Okay. So if there is any problem in renal perfusion to the kidney, that will result in what is called pre-renal type of acute kidney injury. Right? The word pre-renal means perfusion to the kidney is reduced. Then intrinsic renal. Intrinsic renal means where the pathology is directly in the kidney itself. The kidney is damaged. That is intrinsic renal. And if the pathology is outside the kidney, that is in the ureters or like in the bladder, that will be post-renal type of acute kidney injury. So these are the 3 ways by we can divide the etiology. So if you see the etiologies of acute kidney injury, right, we classify this into pre-renal, then intrinsic renal, then we have post-renal. So pre-renal means where perfusion to the kidney is reduced. That is what is your pre-renal. Then what do you mean by this intrinsic renal? Intrinsic renal is that where the pathology is in the kidney. That is intrinsic renal. Post-renal means where pathology is outside the kidney. Okay. So perfusion to the kidney. How much is the normal perfusion we have discussed? That is 20% of the cardiac output that goes to the kidney. 20% of the cardiac output goes to the kidney. And if it is reduced, that will result in what is called pre-renal. Now, what are the pre-renal pathologies? Right? What are the pre-renal conditions? So I have already said you now the concept. Pre-renal means perfusion to the kidney is reduced. Now, can anyone tell me what are all the various pre-renal causes? For acute kidney injury? No, Jacob, renal artery stenosis will cause chronic renal failure, but it will not cause acute renal failure. It is not. Yeah, very good. Yes. So that is your dehydration, shock, volume depletion, diarrhea, right? Any other? Okay, right. Let me tell you all the etiologies. Number one, the pre-renal, it could be because of intravascular volume depletion. Right? Intravascular volume depletion. That is one important problem. Next is because of decreased cardiac output. Right? There can be reduced renal perfusion. Next is renal vasoconstriction. There is another important pre-renal pathology. Next is impaired autoregulation. So these are the pre-renal causes for the acute kidney injury. Now, what are the conditions where there is intravascular volume depletion? Intravascular volume depletion, you can have that in hemorrhage, right? So there is some road traffic accident, or the individual had any trauma, the individual has undergone some surgery, right? Or postpartum hemorrhage, there will be intravascular volume depletion. Next is gastrointestinal loss, right? The patient said that there is excessive vomiting, where there are nearly around 10 to 15 episodes of large volumes of vomiting. So the fluid volume reduces. Like, or you take diarrhea. Patient says almost like 10 to 15 episodes of diarrhea, loose watery diarrhea. So that can reduce the intravascular volume. Next is the renal losses. Right, renal losses. So what are the renal losses? Right, where you will have intravascular volume depletion is endocrine pathologies, right? So can anyone tell me one endocrine pathology where there can be renal loss of the fluid? Is your endocrinology done? No. Okay. But Jacob, remember, you are telling diabetes insipidus. In diabetes insipidus, at the same time, the patient is also consuming water in the excess quantity. Okay. So that will not cause volume depletion in diabetes insipidus. Very good, Vinita. Excellent. So that is Addison's. So the renal losses, example is Addison's. Vinita, can you tell me which hormone deficiency will cause the renal loss in Addison's? Which hormone deficiency will cause the renal loss in Addison's? Any one of you? Very good. That is your aldosterone deficiency. That is your aldosterone deficiency. Then you take the scenarios where there is decreased cardiac output. Even this decreased cardiac output also will decrease the intravascular volume. And what are those decreased cardiac output conditions? These decreased cardiac output conditions include congestive heart failure, then valvular pathologies like aortic stenosis, mitral regurgitation, then aortic regurgitation. Then even certain cardiomyopathies, right? Even cardiomyopathies, there can be decreased cardiac output, reducing the intravascular volume and decreasing the renal perfusion, right? And the other scenario is the embolisms, right? And the embolism which is originating from the heart going into the renal circulation. Okay. Now coming to renal vasoconstriction. Now, Vinita, you said me like liver cirrhosis. Can you tell me the mechanism of liver cirrhosis causing decreased renal perfusion? But whatever you have said is correct. But can you tell me which scenario you will have cirrhosis causing, decreased renal, how does cirrhosis will cause decreased renal perfusion is my question. Anyone? That is in cirrhosis. No. In cirrhosis, why there will be like, okay, Jacob, like to certain extent, okay, to certain extent you are correct, where there can be decreased intravascular volume because of your hypoalbuminemia. And another important is, right, another important point is the one. These patients, they also develop transfer of IV volume to EV volume. Okay. The another way by which the cirrhosis of liver will cause pre-renal type of acute renal failure is, that is by cirrhosis causing hepatorenal syndrome. In cirrhosis, one of the complication is the hepatorenal syndrome. And when there is hepatorenal syndrome, there is renal artery vasoconstriction in cirrhosis of liver. And that can cause decreased perfusion to the kidney, causing pre-renal type of acute renal failure. The other conditions where you can have, I hope everyone has understood this. So decreased renal perfusion to the kidney in cirrhosis, it is mainly because of your third space loss. Second one is renal vasoconstriction as a part of your hepatorenal syndrome. Then the renal vasoconstriction can also be seen in sepsis. And renal vasoconstriction can also be seen in hypercalcemia. Okay, these are the conditions where there will be renal vasoconstriction. And impaired autoregulation. Impaired autoregulation is being done by two important molecules or the drugs. What is that two molecule is? NSAIDs, ACE inhibitors or angiotensin receptor blockers. ACE inhibitors are angiotensin receptor blockers. Now I'll just show you this ACE inhibitors and NSAIDs. How do they cause pre-renal type of acute renal failure? Now you just see this image, right? You closely observe this image here. You have the afferent arteriole. This afferent arteriole, it will undergo vasodilatation by prostaglandins. Prostaglandins are the one which will cause the afferent arteriolar dilatation. That is, if the prostaglandins are there, the afferent arteriole will be dilated and thereby there will be adequate renal perfusion. But if suppose, if prostaglandins are not there, in which scenario they will not be there? When the patient is taking NSAIDs. When the patient is taking NSAIDs, they are like prostaglandin synthesis inhibitors, thereby the afferent arteriolar dilatation does not occur. Once the afferent arteriolar dilatation does not occur, that will cause decreased renal perfusion. That will cause decreased renal perfusion. Okay, that is your NSAIDs. Coming to the ACE inhibitors. Now, how will this ACE inhibitors will contribute to the pre-renal type of acute renal failure? Let me tell you. So you have physiological activation of RAS, right? that RAS which is activated will form angiotensin 2. This angiotensin 2 will cause efferent arteriolar vasoconstriction. Right? Angiotensin 2 will cause efferent arteriolar vasoconstriction. Thereby, what will happen to the movement of the fluid from the glomerulus to the efferent arteriole? That will be reduced because efferent arteriole is in constricted way. Thereby, what will happen to your glomerular pressure is glomerular pressure increases and there will be increase in the glomerular perfusion. Thereby, there will be glomerular perfusion. That is, if you are having the angiotensin 2, efferent arteriole will be vasoconstricted. Thereby, the blood from the glomerulus will not enter into the efferent arteriole. Glomerular pressure increases and thereby glomerular perfusion also increases. For example, you have given ACE inhibitor or you have given angiotensin receptor blocker. What these drugs will do? These drugs will inhibit the angiotensin 2, right? So these drugs, they will inhibit the angiotensin 2. So once your angiotensin 2 is inhibited, the efferent arteriolar constriction does not occur, right? Efferent arterial constriction does not occur if the angiotensin 2 is not there. When efferent arteriolar constriction does not occur, what happens? The fluid from the glomerulus will easily enter into the efferent arteriole. The fluid from the glomerulus easily enters into your efferent arteriole, thereby decreasing the renal perfusion. Right? Thereby decreasing the renal perfusion. Okay. So because of which the individual will end up in pre-renal type of acute kidney injury. So both of these, have you understood this? NSAIDs and the ACE inhibitors. Just give me a thumbs up if you have understood these two mechanisms. If you did not understand, please let me know. So these are the etiologies that will be causing pre-renal. So what we have discussed is this pre-renal is what we have discussed. Then you take this intrinsic renal. You take this intrinsic renal. So intrinsic renal, what did I tell you? Right? It is the pathology within the kidney. That is what is called as the intrinsic renal. Now, what are the intrinsic renal causes? The intrinsic renal causes, that includes the pathology in the glomerulus, right? So one is your glomerular pathology. Next is pathology can be in the tubule, and pathology can be in the interstitium of the kidney. These are the three important parts of structures which are present within the kidney. Now, you take the glomerular pathologies. The glomerular pathologies, they are mainly glomerulonephritis. Right, that includes nephrotic syndrome and as well as nephritic syndrome. Then hemolytic uremic syndrome. Hemolytic uremic syndrome. Then thrombotic thrombocytopenic purpura. Both of these conditions are very, very important. I will discuss them. Then disseminated intravascular coagulation. And another important is malignant hypertension. Okay, so these are the glomerular pathologies. But out of this, the most common will be the glomerulonephritis. Then coming to the tubular pathologies. The tubular pathologies, we call them as the acute tubular necrosis. And the tubule can be damaged because of ischemia, right? And the tubule can also be damaged because of the toxins. Now, what are the toxins which can cause damage to the tubule is, we have endogenous toxins, that means the toxins which are produced within the kidney. Then we have exogenous toxins. right? Then we have exogenous toxins. Okay, so first you take the endogenous toxins. That means the toxins which are produced within the kidney. And these toxins are like, I said you, like in the crush injury, whenever there is rhabdomyolysis, what is the substance that will be released into the circulation? That is myoglobin. So this myoglobin, when it is passing through the renal tubule, can cause damage to the renal tubule, causing acute tubular necrosis. Next, in hemolysis, that is hemoglobinuria, where there will be excess amount of hemoglobin is released into the circulation, passing through the tubule, causing damage to the tubule. Then in case of multiple myeloma, what are the abnormal substances which are formed in multiple myeloma? That is light chains. So these light chains, whenever they are passing through the kidney, they can damage the kidney. They can damage the kidney. And in cases of gout or gouty arthritis, it is the uric acid crystals. Right, it is the uric acid crystals which can accumulate within the kidney, causing acute tubular necrosis. Then followed by that, tumor lysis syndrome. Right, followed by that, the tumor lysis syndrome. Now in tumor lysis syndrome, what is that endogenous toxin? Like, let us just assume a patient has been given chemotherapy for a tumor. A patient has been given the chemotherapy for the tumor. And after 2 days, he came back to you with complete renal shutdown. Right? He says that there is no urine output. My abdomen is completely bloated. All over the body, that like completely swollen. What is this? That could be tumor lysis syndrome. Why? What is this? After giving the chemotherapy is destroying all the tumor cells, and the tumor cells are rich in nucleic acid substances. And these nucleic acids, whenever they are broken, the end product of your chemotherapy causing tumor lysis, that will be the uric acid again. The end product of your nucleic acid degeneration is your uric acid. So if that particular uric acid is produced in excess quantity, and when it is passing through the kidney, or abnormal tumor materials, when they are passing through the kidney, they can damage and destroy the kidney, and that is what is nothing but your tumor lysis syndrome. Okay, right. These are all endogenous toxins, and very important is the exogenous toxins. These exogenous toxins, they include exogenous toxins, they include the anti-cancer agents. What are those anti-cancer agents? Like your cisplatin can cause your acute tubular necrosis. And we have many antibiotics, right? Many antibiotics are there. What are these antibiotics is, that includes amphotericin B can cause acute tubular necrosis. Aminoglycosides can cause acute tubular necrosis. Another important antibiotic is cephaloridin, that can cause the acute tubular necrosis. And calcineurin inhibitor, that is cyclosporin, that can cause acute tubular necrosis. Then we have the anti-neoplastic drugs or anti-cancer agents, that is cisplatin, that can cause acute tubular necrosis. And followed by that, the contrast material. That we call it as contrast induced nephropathy. So this contrast induced nephropathy, right? Contrast induced nephropathy, we come across these cases very commonly. When you do a coronary angiogram or you have done an angioplasty, on third day or on second day, you will observe that there is spike in the creatinine. What could that suggest? That suggests contrast induced nephropathy. How do we treat and all? I will discuss. And then we have few more drugs which can contribute to your acute tubular necrosis. That is tenofovir. Can anyone tell me what is tenofovir? Yes, what is tenofovir? Quickly. Yeah, so it is nucleoside reverse transcriptase inhibitors. For which all viral infection we use this? Not only for retroviral infection, we also use this for the treatment of, very good Manisha, that is in hepatitis B also we use this, right? Then zoledronic acid. Where do we use zoledronic acid? Yes, anyone? What are the conditions where we use zoledronic acid? Osteoporosis. Basically, it is a bisphosphonate, right? And it will prevent the bone resorption. Okay, that is what is your the zoledronic acid. Then the next important is the interstitium, pathology in the interstitium. So if you see the pathology in the interstitium causing interstitial nephritis, that can be seen secondary to infections. And what are the infections that can cause interstitial nephritis is leptospirosis. And not only that, the interstitium can also be affected by drugs, and that we call it as allergic interstitial nephritis. What will be the abnormal urinary abnormality in allergic interstitial nephritis? You see that secondary to antibiotics or even NSAIDs. Very good. So in case of allergic interstitial nephritis, we have discussed that there will be presence of eosinophils in the urine. And acute interstitial tubulointerstitial disease can also be seen as a part of the infiltrative disorders like lymphoma and as well as the leukemia. Right, lymphoma and as well as leukemia. Okay, so this is about glomerular pathologies, tubular pathologies, then interstitial pathologies that would be responsible for intrinsic type of acute renal failure. So what all we have discussed, you see here, we have done the pre-renal causes for acute kidney injury, intrinsic we have discussed. Then you take post-renal. Post-renal is what? Where the pathology is outside the kidney, right? We had a patient like presenting with very severe pain in the loin area, and that particular pain was also radiating to the front. And when we have done the workup, we have found that the serum creatinine levels are elevated. What could be the cause? Can anyone tell me? Pain in the loin area, radiating to the groin, severe pain, right? And the pain is also associated with vomiting. And on workup, the creatinine is elevated. Very good, Hari. That is ureteric caliculi. Okay, so the post-renal causes, as just now I have discussed, the pathology is outside the kidney. Okay, so the etiologies are ureteric caliculi, then bladder caliculi, then bladder malignancies or bladder carcinoma. What is a parasitic infection where you can have bladder carcinoma? Parasitic infection where you will have bladder carcinoma. Very good. That is schistosoma. Schistosoma will cause. Then the other important post-renal cause will be benign prostatic hyperplasia, right? That is the most common cause of post-renal type of acute renal failure in males. That would be your benign prostatic hyperplasia. Then the other postrenal causes will be renal vein thrombosis. Right, renal vein thrombosis. So these are the postrenal causes. And one more important postrenal cause, that is bilateral ureteric fibrosis. So bilateral ureteric fibrosis is seen in connective tissue disorders. What is that connective tissue disorder? Where there is excessive accumulation of the fibrous tissue, right? A female came to me on one particular day, right? The female appearance was like the skin was very tight and she was unable to open the mouth completely. And there is also pitting of the nails, and the skin even in the fingers was very, very tight. And there are also digital ulcers. Very good. That is scleroderma. Okay. Now, we also have drugs which are causing your bilateral ureteric fibrosis. Now, a patient has come to me, right? He had a pleural effusion, and symptomatic pleural effusion was there. I have done thoracocentesis and sent the patient. Again, after 6 months, he came with dyspnea. When I've done a chest X-ray, there was massive pleural effusion again, right? And we have treated the underlying cause, and then we have done a thoracocentesis, and then we have sent. Again, the patient has come with the same pleural effusion. What would be the treatment for recurrent pleural effusion, or what would be the treatment for recurrent pneumothorax? Yes. Do you know what do you mean by the word catamenial pneumothorax? What is mean by catamenial pneumothorax? Anyone? Is your pulmonology done? Respiratory system? Yes, very good, Jacob. So, catamenial pneumothorax means the pneumothorax which will develop during menstruation, and that is due to pulmonary endometriosis. Okay, so the drugs what we give for pleurodesis. Does anyone know what are the drugs which are given for pleurodesis? Pleurodesis means you obliterate the pleura, and obliteration of the pleura can be done by bleomycin. Right, the bleomycin. Okay, and the another important drug is methisargide. Right, other important drug is methisargide. So these are the two drugs which can cause the ureteric fibrosis, that is bilateral ureteric fibrosis. Okay, so this completes the discussion of your postrenal type of acute. So whenever there is bilateral ureteric fibrosis, how will be the picture? I'll tell you, or I'll show you. Right, so this is the picture of bilateral ureteric fibrosis. Both the ureters have been completely fibrosed. Right. Next, then we will try to take up the discussion of the prerenal, the differences. Postrenal, right, it is very easy for you to make out, that is by the presence of obstruction outside the kidney, that is ureteric calculi, bladder calculi, bilateral ureteric fibrosis, bladder carcinoma, benign prostatic hyperplasia, and then renal vein thrombosis. The next important is, how will you differentiate prerenal from intrinsic renal? Postrenal, you will be able to pick up by ultrasonography also. USG will show you that there is some stones or some obstruction, benign prostatic hyperplasia or whatever it is. But how will you differentiate the prerenal from the intrinsic renal? So before going on to the differentiation between prerenal from intrinsic, okay, can you tell me like one urine investigation which will be able to differentiate prerenal and intrinsic renal? I have discussed. Any one of you? How will you differentiate prerenal and intrinsic renal based on urine analysis? I have discussed and I have taught you as well. Very good, Vinita. That is based on the specific gravity. Excellent, Kiki and Rohita Yadav. So now you need to know, okay, one is your specific gravity. I'll be discussing about the specific gravity. Okay. Then another very important parameter which will differentiate which helps in differentiating pre-renal from intrinsic renal is that is based on fraction excretion of the sodium. And this we call it as FeNA. FeNA is what? Fraction excretion of sodium is what is nothing but your FeNA. What is the formula for your FeNA is urine sodium by plasma sodium multiplied by 100. Okay. Actually, we also have creatinine also in the formula, that is plasma creatinine divided by urine creatinine. So this is what is the formula for the fraction excretion of sodium. Okay. Now I'll ask, in case of pre-renal, what is the problem in pre-renal? That is perfusion to the kidney is reduced. That is what is your pre-renal. What is intrinsic renal? Most common cause will be acute tubular necrosis. Okay. Now, I just want to ask you a quick question here. In pre-renal, or is it in intrinsic renal, where will you have more urinary sodium? Large quantity of the urinary sodium. Very good, Jacob. Because intrinsic renal, the urinary sodium is increased. Why? Because there is acute tubular necrosis. The sodium absorption does not occur. Is there any problem in the renal perfusion in intrinsic? There is no problem in the renal perfusion in intrinsic, but the tubules are not absorbing the sodium. That is the reason why if you take the urinary sodium in intrinsic renal, it is more than 20 milliequivalents, whereas in pre-renal, it is just only less than 10 milliequivalents. Now, we will try to apply the concept of this urinary sodium in the FeNA as well. That is fraction excretion of sodium. Okay. So now in pre-renal, we have discussed that the urinary sodium is less. Why? Because the renal perfusion is decreased. So the amount of sodium which is coming to the kidney is reduced, and the amount of sodium in the urine is also reduced. Okay. The amount of sodium in the urine is also reduced in case of your pre-renal. Now tell me, what will happen to this ratio in case of the pre-renal? Anyone? What will happen to this ratio in pre-renal? That will be decreased. Very good, Jacob. And you know the value will be less than 1. Because urinary sodium will be less, plasma sodium will be more in case of pre-renal. So the ratio will be less than 1. Whereas you take an intrinsic renal. In intrinsic renal, the perfusion is adequate. The perfusion to the kidney is adequate. And at the same time, the absorption of the sodium is not there at the level of your tubules. So what will happen to urinary sodium in intrinsic renal? It is increased. So urine sodium will be more than compared to that of the plasma sodium. So ratio will be more than 1. Ratio will be more than 1. So this is a very, very important parameter which will differentiate pre-renal from intrinsic renal. Then the another important parameter which helps in differentiation is urine osmolality. So please tell me, in which scenario the urine osmolality will be more? Because we have discussed the concept now, you should know, or you should tell me in which conditions the urine sodium will be, urine osmolality will be more. Swati, can you just elaborate your answer, because you just said renal. So is it pre-renal or intrinsic renal, Swati? Intrinsic renal, okay. None of you have said a correct answer. The urine osmolality is more in pre-renal than the intrinsic renal. I'll tell you why. Now, in pre-renal, what is happening to renal perfusion? Renal perfusion is decreased. When renal perfusion is decreased, how will be the urine? The urine that you will have is a highly concentrated urine in case of pre-renal, right? In intrinsic renal, okay, you are anticipating that, sir, sodium is not absorbed, the urinary sodium is increased, so that is the reason why urine osmolality should also increase. That is what is your anticipation in intrinsic renal. But remember, when there is acute tubular necrosis, the fluid which has to be absorbed, will that be absorbed? What will happen to water reabsorption if there is acute tubular necrosis? Water reabsorption is also decreased. Very good, Vinita. So now, in cases of intrinsic renal, water and as well as sodium, both of them have excreted out, right? And the amount of water which is excreted out is much more than compared to that of sodium. That is the reason why the urine osmolality is 350, right? Yes, Jacob, what is your question? So, if perfusion is less, wouldn't the solute delivered to the kidney also be less? Yeah, obviously, but the urine, what will be the concentration of the urine, Jacob? According to you, correct. The sodium which is delivered to the kidney is also reduced. But overall, what will be the concentration of the urine? The concentration of the urine will be high because some amount of fluid is going and some amount of solute is going. But relatively, it is highly concentrated urine in prerenal. But in intrinsic renal, when there is acute tubular necrosis, it is not only sodium excreted, it is also water which is excreted. So that is the reason why the urine osmolality is 350 then compared to that of 500 in prerenal. Jacob, did you understand what I have said? And what about others? Did you get the explanation clear or do you have any doubts still? Because tubular function is intact, there is hypovolemia, so more water has to be absorbed. Jacob, where are you talking this about? Are you talking in prerenal? Yes, your point is very much valid, Jacob. The tubular function is intact, so the fluid which is like filtering, that will be absorbed. Thereby, what will happen to concentration of the urine, Jacob? The amount of the urine which has been excreted by the individual, the concentration is increased. So thereby the urine osmolality is like more than 500. But in case of intrinsic renal, there is tubular damage and water is not reabsorbed. And even the perfusion is also good in intrinsic renal. So water is getting excreted out, sodium is also getting excreted out. But the amount of water which is excreted is more than compared to that of the sodium. That is the reason why the urine osmolality is around 350. Did you understand, all of you? If anyone, you have any doubt, please let me know. If you have understood, just give me a thumbs up. All right. Then now the next point is, which samples will have more urine specific gravity? Yeah. Urine creatinine ratio is also used. I'll tell you about that, Jacob. I'll tell you. Yes, Maheshwari, you are right, Maheshwari. In prerenal, reabsorption is good. So the urine concentration is increased. Right? Urine, I'm not talking about urine sodium concentration, Maheshwari. Urine concentration is increased. In prerenal, two things are happening. One is perfusion is reduced, and the other point is whatever the perfusion is going on to the kidney, absorption is also taking into that particular fluid. So overall, the concentrated urine you will have in prerenal. Okay, so which one will have more urine specific gravity now? Very good, Vinita. So specific gravity in case of the prerenal, it is more than 1.030. Whereas intrinsic renal, water is also excreted out along with the sodium. That is the reason it is 1.010 in case of the intrinsic renal. Then you take the urinary sediment. In prerenal, you don't have pathology directly within the kidney. You will have the presence of the normal cast. What is the normal cast in the urine we have discussed? What is the normal cast that can be there in the urine? Very good, Ritika. That is right. That is that hyaline cast will be there. Okay. Then you take in case of the intrinsic renal. In intrinsic renal, you have the presence of the granular cast. Right. And another very important difference is, as Jacob was telling, that is plasma blood urea nitrogen to that of the serum creatinine ratio. It is more than 20 in pre-renal. It is 10 to 15, that is in intrinsic renal. This is a very, very important difference. Bun to creatinine ratio. Okay. And another important point is urine creatinine ratio to plasma creatinine ratio. Right, urine creatinine ratio to the plasma creatinine ratio. Urine creatinine ratio to the plasma creatinine ratio in pre-renal, it is more than 40, whereas in intrinsic renal, it is less than 20. Okay, so these are the differences between pre-renal and intrinsic renal, out of which FeNA is very important to be remembered. Then Bun to creatinine ratio is also very important to be remembered. And next is the urinary sodium. So these three differences, though, definitely you have to remember, right? Then coming to relation between blood urea nitrogen and as well as urea. Blood urea nitrogen is almost 2 times that of the value of the urea levels. Is that clear, Jacob? Blood urea nitrogen is almost 2 times that of the urea levels. That is what is the relation between the blood urea nitrogen and as well as the urea. Both are not same. Blood urea nitrogen and urea, both are not same. Okay, right. So after having discussed about differences between pre-renal and as well as the intrinsic renal, now let me talk about so you take the urine creatinine to that of the plasma creatinine value. If you observe the values in pre-renal, like we are considering it as the values being more than 40 in case of the pre-renal, and intrinsic renal, it is less than 20. So how is it like being assumed? It is being assumed in such a way that the urine creatinine is more in case of pre-renal, right? Or it could be the other way around. It could be the other way around also. What is that other way around? Or plasma creatinine should be decreased. Okay, so this is what is your interpretation. Either the urine creatinine should be more, or the plasma creatinine should be less. Then only the value will be more in pre-renal, and the value will be exactly opposite in case of the intrinsic renal. Now, you take the urine creatinine in case of the pre-renal. We were discussing about the urine osmolality being increased in pre-renal. This is mainly because of 2 reasons. One is because of decreased fluid in the urine, along with that because of increased urine creatinine. Okay, so these are the 2 things which will contribute to your increase in urine osmolality in pre-renal then compared to that of the intrinsic renal. Now, the question is, why the urine creatinine is more in pre-renal than compared to that of the intrinsic renal? Jacob, you see the etiologies which are causing pre-renal. The etiologies causing pre-renal, they are the one which are decreasing the renal perfusion. What are those etiologies? Basically, like decreased volume, that could be because of diarrhea, vomiting, so on and so forth. That could be because of decreased cardiac output, that is causing reduction in the blood pressure. So now tell me, Jacob, these etiologies, what they will do to perfusion to the muscles also. These prerenal conditions, perfusion to the muscles also decreased. When perfusion to the muscles is decreased, Jacob, tell me now, what will happen to the amount of creatinine which is produced? Is it more in prerenal or is it more in the intrinsic renal? The amount of the creatinine produced. The amount of creatinine produced, is it more in prerenal or is it more in intrinsic renal? Yes? No. Why are you telling intrinsic renal? See, in case of prerenal, the amount of the creatinine produced is more. So in prerenal, why there is increased creatinine produced? Because in prerenal, there is also decreased muscle perfusion. When there is decreased muscle perfusion, so muscle is getting excessively degenerated. When muscle is excessively getting degenerated, right, thereby what will happen to the creatinine produced? Muscle is dying there. Muscle is becoming hypoxic in case of prerenal etiologies. When muscle is becoming hypoxic, more and more muscle gets degenerated and more creatinine will be produced. And this more and more creatinine which is being produced, that will start getting excreted in the urine. Thereby, your urine creatinine will be more. Thereby, the urine creatinine will be more. When urine creatinine is more, the urine creatinine to plasma creatinine ratio is also increased to more than 40. Did you understand that, Jacob? So basically what you have to understand here is the pathophysiologies which are causing prerenal are also affecting the muscle perfusion. When the muscle perfusion is affected, the muscle is degenerated. So more and more muscle degeneration, more and more creatinine production, more and more excretion of the urine creatinine. That will result in the urine creatinine to plasma creatinine ratio more than 40. Okay, right. So that was about the differences between prerenal and as well as the intrinsic renal. Now you take the clinical features. Right. The clinical features, first and foremost, the urine output, that will be decreased. Right, urine output is decreased. So once the urine output is decreased, what will happen to the fluid volume? Increases. And you will have the features of increased fluid volume. And subsequently, what will happen to the urea levels? Because the nitrogenous waste products are elevated. So urea level is also increased. Now, once the urine output is reduced, how much will be that reduced? The individual may go into a state of oliguria. When do you call oliguria? When the urine output is less than 400 ml per 24 hours. We call it as the oliguria. And as the severity of the acute kidney injury increases, the oliguria will go into a state of anuria. Right? When do we call anuria? When the urine output is less than 100 ml per 24 hours. This we call it as the anuria. Okay. Then in the urine abnormalities, you should also know where do you have red color urine in cases of acute kidney injury. That is nothing but your pigment nephropathy, and you get this in case of red or brown urine. Right, red or brown urine, you see that in rhabdomyolysis, that is where there is crush injury. right? Or hemolysis. Okay, so these are the conditions where you'll have red or brown urine. So this is abnormality related to the urine output and as well as urine color in acute kidney injury. And at the same time, the fluid volume is increased. When the fluid volume is increased, right? So because of the increase in the fluid volume, the fluid will accumulate in the various parts of the body. Where all the fluid can accumulate? In the third spaces. So there can be periorbital edema because of the fluid overload. There can be also the pleural effusion. Remove this. So pleural effusion. There can be development of pericardial effusion. And another important cardiac abnormality that you can have because of the fluid abnormality is hypertension, right? And the fluid will also accumulate in the third space. That will result in ascites, right? And the fluid will also accumulate in the legs. That will result in pedal edema. Okay, so these are the abnormalities because of the fluid overload. And because of the pleural effusion and pericardial effusion, what will be the patient presentation? Because of the pleural effusion or pericardial effusion, these patients, they present with dyspnea. They present with dyspnea, right? And at the same increase in the urea levels. And because of this, all the urea can accumulate. This urea, uremic encephalopathy. Because of increase in the urea levels, there can be uremic encephalopathy, and urea will also accumulate within the pericardium, resulting in uremic pericarditis. Be in a state of altered sensorium. And there can be also uremic gastroparesis. They present with constipation. Okay, so these are the clinical manifestations that you will have, right? So these are the clinical manifestations. One is because of decrease in the urine output, the other is because of increase in the fluid volume, and the other is because of increase in the urea levels, right? Yes, Jacob, at what levels of urea can we say that encephalopathy is due to urea, sir? Now, let me just tell you, Jacob, there is no particular cutoff value. At this particular point, the individual will develop uremic encephalopathy. It all depends upon the individual personality, right? Because in children, the urea levels, if they are increased to around 50 or 60 international units per liter, there can be development of encephalopathy. Whereas in adults, when the urea levels are increased around 90 or 100, then they can develop uremic encephalopathy. But how can you tell that the individual has developed uremic encephalopathy? Is altered sensorium, and then you have this on examination presence of the flapping tremors. Okay, so these are the two things which will tell us the individual has gone into uremic encephalopathy. But there is no cutoff value that at this point the individual will develop uremic encephalopathy. It all depends upon the individual variation, right? Then you should know at the same time, can anyone tell me what are the differential diagnoses for the flapping tremors? Anyone? What are the differential diagnoses for flapping tremors? What are the other conditions? The other conditions, very good, Jacob. You also have that in case of the hepatic encephalopathy. Then carbon dioxide narcosis. These are the two other conditions where you can have the presence of the flapping tremors, right? So this is about your clinical manifestations that you come across in patients with the acute kidney injury. And these patients with acute kidney injury, because of oliguria, they also suffer with certain electrolyte abnormalities, right? What are the electrolyte abnormalities that can be observed? Electrolyte and metabolic abnormalities that can be observed in acute kidney injury during this severe form of oliguria. The electrolyte abnormality can be like hyperkalemia, then hypermagnesemia, then hyperphosphatemia, and then increase in the uric acid levels. Why? Because all these substances, they have to be excreted by the kidney, and when the kidney is not functioning, these substances, they get accumulated in our body, resulting in hyperkalemia, hypermagnesemia, hyperphosphatemia, and as well as increase in the uric acid levels. Then followed by that, you take the sodium. The sodium levels, they are reduced, right? Yes. So why there will be hyponatremia? And hyponatremia will be there. There will be also hypocalcemia, and very rarely there can be anemia also. So why there is hyponatremia? The hyponatremia is because of the dilution effect. Because whenever there is oliguria, what will happen to the fluid level in the body? The fluid levels in the body increases, and that will cause the dilution of the sodium, and that will result in what is called dilutional hyponatremia. Then you take the calcium. Why there is hypocalcemia? That is not because of decrease in vitamin D synthesis, because acute kidney injury is the one which will develop within 2 to 3 days or within 1 week of the clinical insult. That is because of the underlying etiology. So the hypocalcemia that you are observing, why is that you will have that hypocalcemia, is because the calcium, it will combine with phosphate, because the phosphate levels are elevated, right? So the calcium will combine with phosphate, resulting in calcium phosphate. The ionic calcium level increases, but the phosphate is keep on increasing because it is not getting excreted. Okay, so there will be hypocalcemia because of the calcium phosphate formation. And when will you have anemia? That is, I said you, hemolysis, right? Hemolysis. That is your hemoglobinuria. That is your hemoglobinuria. That is what is responsible for the acute kidney injury. So whenever there is hemolytic anemias causing acute kidney injury, in them there can be presence of anemia. There can be presence of anemia. Okay, so that completes the discussion of the abnormalities or the clinical features within the individual. Now let us just take up the workup, that is the investigations. So until now, whatever we have discussed, I'll just show you. First important thing, I've discussed about the definition according to KDIGO guidelines, acute kidney injury network criteria, and then Rifle criteria. Then followed by that, we have discussed the etiology, in which we have classified it as pre-renal, intrinsic renal, and then the post-renal, right? And then followed by that, we have discussed how to differentiate the pre-renal from the intrinsic renal. Okay. Then followed by that, we have discussed the clinical features based on the urine output, based on increase in the fluid volume in the body, right? So this is increase in the fluid volume in the body. And at the same time, like what will be the clinical features because of increase in the urea levels. Okay, right. Now followed by that, okay. Right. Kamalanathan is asking, sir, in tubular type of acute kidney injury, how is the urine output? Urine output in case of tubular type of acute kidney injury is also decreased. There will be oliguria even in case of acute tubular necrosis also. But there is one exception. That is, patient having tubular pathology, but there is polyuria instead of oliguria in cases of acute kidney injury. Can anyone tell me what is that? Yes, Kamalnathan, can you tell me? In tubular type, Very good, Vinita. That is nephrogenic diabetes insipidus caused by aminoglycosides, caused by amphotericin B, right? Otherwise, in tubular type of acute kidney injury, also you will have decrease in the urine output, but exception is aminoglycoside induced or amphotericin B induced tubular injury, you will have increase in the urine output. Yes, Kamalnathan, is that clear, Kamalnathan? Then followed by that. Okay. Now you may ask me, right, sir, in case of tubular type, the tubule is getting damaged, water will not be absorbed, so there should be polyuria. That might be thought process of some of the students, but what you have to remember is whenever there is tubular necrosis, the filtration itself does not occur from the glomerulus. The filtration has to occur into the tubule. The filtration into the tubule itself is completely lost whenever there is acute tubular necrosis. So thereby, the individual will have decrease in the urine output in case of acute tubular necrosis. Okay. Now you take the workup. That is investigations. So if you take the workup, first and foremost, the serum creatinine. What will happen to the serum creatinine value? Definitely it increases. But there is a particular pattern. No, Jacob, acute tubular necrosis is different. Glomerulonephritis is different. See, how did we classify the etiology of intrinsic? But one can overlap the other. One can overlap the other. But you see, we have discussed glomerular pathologies separately causing intrinsic type of acute kidney injury, and tubular pathologies we have discussed separately causing the intrinsic type of acute kidney injury. Now, you take these particular toxins. The toxins can overlap. They can cause acute tubular necrosis and they can cause glomerulonephritis also simultaneously. But both of these entities are separate. Glomerular pathologies and tubular pathologies, both of them are separate. Okay. Yes, Jacob, did you get that point or did you understand that? Right. So the serum creatinine is elevated in patients with the acute kidney injury, but there is one particular pattern of rise in serum creatinine in contrast-induced nephropathy. So if you take in CIN, what do you mean by the word CIN? CIN stands for contrast-induced nephropathy. So in contrast-induced nephropathy, the serum creatinine will start rising. How much it will rise? It will increase within 24 to 48 hours. Right? It will increase within 24 to 48 hours. And when it will reach the peak value, it reaches the peak value within 3 to 5 days. Right? And within, when will this serum creatinine will get normalized? Within 5 to 7 days. Right, within 5 to 7 days, the serum creatinine will come to the normal value. Okay, so that is in case of contrast-induced nephropathy. What will happen to the serum creatinine? Right. Then next is the complete blood picture. The another workup is complete blood picture. If you take the complete blood picture, there can be anemia. When will you have anemia? You will have anemia when there is hemolytic anemia causing acute kidney injury. The other one is the increase in the eosinophil levels in the complete blood picture. So can anyone tell me which conditions the eosinophil levels will be increased? In which condition the eosinophil levels will be increased? In the complete blood picture. Very good, Jacob. That is allergic interstitial nephritis. And the other one is atheroembolic diseases. I was discussing that this in the urine analysis also, atheroembolic diseases. So in atheroembolic diseases, what did I tell you? Like the individual have undergone the coronary angiogram, the plaque is ruptured, and the plaque will descend down to the renal artery and will block the renal artery, where the individual will end up in acute kidney injury, and that will initiate the inflammatory response. The plaque will initiate an inflammatory response, and that will cause increase in the eosinophils. That will cause increase in the eosinophils. That is about your complete blood picture. Then followed by the complete blood picture. Then next is the urine microscopy. So urine microscopy you have to do mainly for examining the presence of the cast, right? Mainly for examining the cast. Okay, right? We have discussed the various types of cast, right? We are not very much concerned here. Next is the electrolytes. What will be the electrolyte abnormalities in the workup? So in the workup, apart from the serum creatinine, complete blood picture, and urine microscopy, the serum electrolytes, you will notice that there is hyperkalemia, there is hyperphosphatemia, there is hypermagnesemia, there is increase in the uric acid levels, right? And there is also hypo, or there will be hypocalcemia, right? And the other important point is there will be hyponatremia. Then these patients, they also have to undergo the ECG. Because of hyperkalemia, what can be the ECG changes? Tall, tented T waves. And because of hypocalcemia, what can be the ECG changes? There can be long QT interval. There can be long QT interval. Okay, that will be the ECG changes. Then we have discussed about the FeNA in the beginning itself, that is fraction excretion of sodium. Then imaging of the abdomen, that is ultrasound abdomen or the CT scan. So when you do imaging, that is ultrasound abdomen or CT scan, that is mainly useful for recognizing the post-renal cause, right? Mainly useful for recognizing the post-renal causes. And another important investigation is the ABG. So ABG, what it will show you, that there is presence of metabolic acidosis. Why there is metabolic acidosis? Metabolic acidosis, it is mainly because of decreased bicarbonate reabsorption at the level of renal tubules. Where is the site of bicarbonate reabsorption? Where is the site of the bicarbonate reabsorption? Right. So the site of bicarbonate reabsorption is PCT, mainly in the PCT, proximal convoluted tubule. So because of abnormality in the PCT, the bicarbonate will not be absorbed. Okay. So that is what is your workup in these patients, right? Then followed by that, you need to know important biomarkers. There are novel biomarkers of the acute kidney injury. So what are the novel in the sense? New biomarkers. These novel biomarkers of the acute kidney injury include, number one, KIM1. This KIM1 stands for kidney injury molecule 1. Right, kidney injury molecule 1. Where is this kidney injury molecule 1 expressed? This is expressed in the proximal convoluted tubule. And second important novel biomarker is that is elevated and that will be useful in assessment of acute kidney injury is neutrophil gelatinase right, neutrophil gelatinase associated lipocalcin. right? That is NGAL. And the next important is the interleukin 18. Next is L-type fatty acid binding protein. Okay, so these are the novel biomarkers of the acute kidney injury, right? And these are, if they are elevated, that tells you that the individual is in a state of the acute kidney injury. Okay, now after having discussed about the workup and then etiology, clinical features, you should know how do you treat these patients. So treatment, it completely depends upon what exactly is the underlying cause. Now, if it is nephrotoxin specific, like rhabdomyolysis causing acute kidney injury, the drug that need to be given for rhabdomyolysis is, or you need to give is, you need to do forced alkaline diuresis. Right? Then you see in case of tumor lysis syndrome. Okay, in tumor lysis syndrome, what is that you should do? What is that substance which is produced in excess quantity? Uric acid. So tell me some examples of uricosuric agents. Tell me some examples of the uricosuric agents. Anyone? Examples of uricosuric agent. Very good, Rohita. Probenecid. Apart from probenecid, rasburicase. Very good, Soumya. So the drug what you need to give in these patients is rasburicase. And at the same time, you should also give the drugs which will reduce the uric acid synthesis. Right? The drug at the same time reducing the uric acid synthesis will be allopurinol. That is xanthine oxidase inhibitor. That is xanthine oxidase inhibitor. Okay. Now, if the cause for acute kidney injury is contrast-induced nephropathy, and in case of contrast-induced nephropathy, so in which group of individuals we have discussed? That is mainly in diabetic patients. Contrast-induced nephropathy is very common. So the treatment that you should give is IV fluids, and the drug of choice for contrast-induced nephropathy is N-acetylcysteine. Actually, N-acetylcysteine is the drug of choice for which poisoning? N-acetylcysteine is the drug of choice for which? Paracetamol poisoning, right? And here also we give the N-acetylcysteine, which will eliminate the contrast. Okay, then the next important is these patients, we have discussed that they are like volume overloaded. So how will you treat that volume overload? Volume overload, you have to treat them by salt and water restriction. Then at the same time you should give diuretics. Now diuretics what we give is furosemide. So please tell me which etiology causing acute kidney injury diuretics cannot be given. Which etiology is causing acute kidney injury diuretics cannot be given? Very good. So in pre-renal type, you should not give the diuretics because in pre-renal already there is reduced fluid volume. Then how will you correct the electrolyte abnormalities? Because these patients are having multiple electrolyte abnormalities. So how will you correct the electrolyte abnormalities? So correction of electrolytes. So I said you that these patients, they have dilutional hyponatremia. Okay. So when there is dilutional hyponatremia, the treatment, if the individual is asymptomatic because of your hyponatremia, the only treatment is restrict the water intake. Okay, restrict the water intake if there is dilutional hyponatremia. And because of this hyponatremia, if the patient is symptomatic, right? Symptomatic hyponatremia, like what would be the symptoms of your hyponatremia? Any one of you? What are the symptoms of the hyponatremia? Anyone? That is altered sensorium, seizures. These are the symptoms of your hyponatremia. So whenever there is symptomatic hyponatremia, you should give hypertonic saline. Right, where we give 3% sodium chloride. Okay, that is in whenever there is symptomatic hyponatremia. Then next important is the hyperkalemia. So how do you treat this hyperkalemia? Can anyone tell me what is the drug of choice for hyperkalemia? Drug of choice for hyperkalemia is calcium gluconate. Yeah. So now this calcium gluconate, please remember, it will not reduce the potassium levels. It will not reduce the potassium levels. Which one? The calcium gluconate will not reduce the potassium levels. Calcium gluconate will only sensitize the myocardial membrane and prevent the development of arrhythmias. Right? Calcium gluconate will only sensitize the myocardial membrane and prevent the development of the arrhythmias. That is what is your calcium gluconate. Then you should give the drugs which will reduce the potassium. What are the drugs that will reduce the potassium? The earliest and as well as fastest reduction of the potassium can be done by insulin plus dextrose. Okay, among all, the fast correction can be done by insulin plus dextrose. And the other drugs which will reduce the potassium levels, that will be salbutamol nebulization. Okay, so both of these drugs, that is insulin and salbutamol, how it will reduce the potassium levels? Please remember, both of these drugs will cause the shift of the potassium, right? Shift of the potassium from extracellular compartment to the intracellular compartment. Right? Shift of the potassium from extracellular compartment to the intracellular compartment. So that is the way by which the hyperkalemia can be corrected. And the other drugs that you should give is the loop diuretics. Sorry. So what these loop diuretics will cause is, loop diuretics will cause the excretion of potassium, right? That will cause, or that will promote urinary potassium loss. That will promote the urinary potassium loss. Then followed by that, we have potassium binding agents. The potassium binding agents, so the loop diuretics will cause loss of potassium in the urine. Then the potassium binding agents, the examples that we have is sodium polystyrene sulfonate. Right? Sodium polystyrene sulfonate. So this sodium polystyrene sulfonate, what it will do? It will bind to the potassium which is there in the gastrointestinal tract, and it will cause the excretion of the potassium. That is what is your sodium polystyrene sulfonate. And in refractory cases, the treatment that we give is hemodialysis. Right? In refractory cases, you need to do the hemodialysis. Okay, so this is about your treatment of the hyperkalemia. Now, Now, after having about the discussion on hyperkalemia treatment, these patients, they are also having hyperphosphatemia and as well as hypocalcemia. So how will you treat the hyperphosphatemia? Okay, the hyperphosphatemia, it is treated by giving phosphate binding agents. So what are the examples of right? What are the examples of the phosphate binding agents? The examples of the phosphate binding agents are calcium acetate, right? The other important example is sevelamer hydrochloride. Then the other important example is aluminium hydroxide. So these are all your phosphate binding agents. That is how you will treat the hyperphosphatemia. Then hypocalcemia. So how do you treat hypocalcemia? The treatment of hypocalcemia, it is by calcium carbonate and other important drug is calcium gluconate. Okay, calcium carbonate or the calcium gluconate. So that is how you will treat the hypocalcemia. Okay. Now, why there is hypocalcemia? That is because the calcium is binding with the phosphate. Then the other abnormalities. So this is about your sodium, potassium, phosphate, and as well as this calcium correction. Then the next important is, right, you should also be able to treat the magnesium. The other important abnormalities that need to be treated is there is hypermagnesemia also in these patients because magnesium is not getting excreted out. So how do you treat the hypermagnesemia is, first and foremost, you should advise the patient to stop taking magnesium containing antacids. Right? Magnesium supplements or magnesium containing antacids has to be stopped. The other thing is IV fluids should be given. What is the purpose of giving IV fluids? Administration of the IV fluids, such as saline solutions, that will help in increasing the urine output and promote the excretion of the magnesium. Okay, so IV fluids will increase magnesium excretion and thereby will normalize the magnesium levels. And you should also give medications. So what are the medications that are given to treat the hypermagnesemia is you need to give loop diuretics, and these loop diuretics include the furosemide. Okay, these are the drugs which are given for treatment of hypermagnesemia. And in refractory cases, you need to do hemodialysis. In refractory cases, you need to do hemodialysis. Okay, that is how you will treat hypermagnesemia. Then followed by that, these patients are also having metabolic acidosis. So how do you treat this metabolic acidosis? For suppose, if the pH, because of metabolic acidosis, what will be the clinical features? What will be the clinical features because of metabolic acidosis? Anyone of you? Hyperventilation. There will be dyspnea in the individual. So when the pH is less than 7.2, or if the bicarbonate levels have been reduced to less than 10, normal bicarbonate levels are how much are the normal bicarbonate levels? Normal bicarbonate levels, please remember, the value is around 22 to 26 milliequivalents per liter. Very good, Jacob. And if the bicarbonate values are less than 10, or if the pH is less than 7.2, that is the point when we need to supplement injection. Sodium bicarbonate should be given. right? Injection sodium bicarbonate should be given. That is for metabolic acidosis, right? Then these patients, what is the indication for dialysis? Right? What is the indication for dialysis? So the indication, no, we don't give for the higher values. That can be tolerated by the individual, and that can get auto-corrected whenever you are trying to treat the other parameters. Only when the pH is less than 7.2 and when the bicarbonate is less than 10, that is indication to give sodium bicarbonate. Okay. Then indications of dialysis. Indications of dialysis is, and okay, one more. These patients, what did we discuss? Because of the fluid overload, there is hypertension in these patients. So how do you treat this hypertension? The hypertension should be treated with by giving labetalol, which is both alpha plus beta blocker. Okay. Now, what are the indications for dialysis? The indications for dialysis, just remember this mnemonic, have P. Okay. So these are the indications for dialysis. Now, what is this have P? Let me tell you. So, this have P in dialysis, H is your hyperkalemia, but it should be refractory hyperkalemia. Then A stands for acidosis, that is refractory acidosis. V stands for volume overload, that is refractory volume overload. E stands for elevated blood urea nitrogen. And how much should be that elevated? More than 35 millimoles per liter. And you take P. P stands for pericarditis. E stands for encephalopathy. And another E is edema. That is pulmonary edema. Okay. So this is what is your have P. These are the indications for dialysis. Refractory hyperkalemia, refractory acidosis, refractory volume overload, elevated blood urea nitrogen levels more than 35 millimoles per liter, uremic pericarditis, uremic encephalopathy, and then pulmonary edema. So these are the indications for the dialysis, right? So this finishes your acute kidney injury, right? So you just quickly, we will just see what we have discussed in AKI. Very important is according to your KDIGO guidelines, the creatinine should be elevated more than 0.3 milligrams per deciliter within 48 hours, and urine volume should be reduced less than 0.5 ml per 6 hours. And acute kidney injury network criteria has given staging 1 to 3. In stage 1, and what parameters have taken into consideration for staging? Creatinine and as well as urine output. So creatinine, like it is increased 1.5 to 2 folds in 1, and stage 2, 2 to 3 folds, and stage 3, more than 3 folds. And what about the urine output? Urine output, it should be less than 0.5 ml per kg per hour for more than 6 hours in stage 1. Stage 2, it is for nearly around 12 hours. And stage 3, it is less than 0.3 ml per kg per hour for nearly around 24 hours. Okay, that is the classification according to your acute kidney injury network criteria. And then we have the rifle criteria. Rifle criteria, when do we use the word? So what is added in your rifle? GFR is added. So risk means the GFR is reduced more than 25%. Injury means the GFR is increased, it is reduced by more than 50%. And failure means the GFR is decreased by more than 75%. Loss of kidney function means where there is complete loss of kidney function for more than 4 weeks. And end-stage renal disease, where there is complete loss of kidney function for more than 3 months. Okay, so that is about your rifle. Etiology, we have classified it as pre-renal, intrinsic renal, and post-renal. Prerenal means where perfusion to the kidney is reduced. Intrinsic renal pathology is within the kidney. Postrenal pathology is outside the kidney. So you take prerenal, right? The causes are classified as decrease in intravascular volume, like in hemorrhage, gastrointestinal loss, or renal loss. Decreased cardiac output, like in cases of congestive heart failure or valvular heart diseases. And renal vasoconstriction, that could be because of your hypercalcemia, sepsis, and liver pathologies. Impaired autoregulation, that is your ACE inhibitors, ARBs, and as well as NSAIDs. And intrinsic pathology, we have classified it as glomerular, tubular, and interstitial causes. Glomerular causes are like glomerulonephritis, or it could be hemolytic uremic syndrome, thrombocytopenic purpura, DIC, and malignant hypertension. Tubular causes will be like ischemia and toxins, and these toxins, they are mainly endo and as well as exogenous toxins. These endogenous toxins, like we have myoglobinuria, hemoglobinuria, light chains, uric acid crystals, and tumor lysis syndrome. And exogenous toxins are mainly drugs, anti-cancer agents like cisplatin, amphotericin B, aminoglycoside, cephaloridin, cyclosporin, and then cisplatin, which is an anti-neoplastic drug, contrast-induced nephropathy, tenofovir, and zoledronic acid. And interstitial nephritis, it is mainly infective pathology, that is your leptospirosis, and even it can be allergic interstitial nephritis secondary to your NSAIDs and as well as the antibiotics. Postrenal pathology is mainly the obstructions outside the kidney, ureteric calculi, bladder calculi, bilateral ureteric fibrosis, benign prostatic hyperplasia, renal vein thrombosis. These are the conditions. Then, how will you differentiate prerenal from intrinsic renal? We have multiple parameters. One important is FeNA. FeNA in case of prerenal, it is less than 1, and intrinsic renal, it is more than 1. Then urine sodium, it is increased in less than 10 in prerenal, more than 20 in intrinsic renal. And urine osmolality and specific gravity, that is also more in prerenal, and it is less than around 350 in case of intrinsic renal. Bun to creatinine ratio is another important, more than 20 in prerenal, less than 10 to 15 in case of intrinsic renal. Next is urine creatinine to plasma creatinine ratio is more than 40 in prerenal, less than 20 in intrinsic renal. The clinical features that you will have is because of decrease in urine output, because of the fluid overload, and because of increase in the urea. Decrease in urine output, they will have oliguria initially, they will have anuria in the later stages. Fluid volume is increased. The fluid can accumulate in the periorbital area, causing periorbital edema. In the third spaces, like pleural effusion, pericardial effusion as ascites, there can be hypertension, then pedal edema. Because of increase in urea levels, there can be uremic encephalopathy, uremic pericarditis, uremic gastroparesis, and the skin becomes dry because of the accumulation of the urea. And electrolyte abnormalities because of your oliguria, hyperkalemia, hypermagnesemia, hyperphosphatemia, increase in uric acid levels, hyponatremia, hypocalcemia, and as well as the anemia. And if you take the workup, the serum creatinine levels are elevated, and particularly in case of contrast-induced nephropathy, you have a peculiar pattern there. Complete blood picture can show anemia or eosinophilia. Eosinophilia will be there in allergic interstitial nephritis and atheroembolic diseases. Urine microscopic examination is done mainly for estimating the cast. Serum electrolytes, right? This is a picture. That is hyperkalemia, hypermagnesemia, hyperphosphatemia, increase in uric acid levels, but sodium levels and calcium levels are reduced. ECG, because of hyperkalemia, you will have tall tentative wave. Because of hypocalcemia, you will have long QT interval. Ultrasound abdomen is done mainly to look for if there is any postrenal pathologies. ABG, you will have metabolic acidosis. Novel biomarkers are KIM1, NGAL, interleukin 18, L-type fatty acid binding protein. Treatment, you need to treat the underlying etiology. Rhabdomyolysis is there, then you need to do forced alkaline diuresis. Tumor lysis syndrome, you need to give rasburicase and allopurinol. Contrast-induced nephropathy, so you need to give IV fluids along with that NAC. And volume overload is there. Then salt and water restriction and diuretics, that is furosemide. Correction of electrolytes. Symptomatic hyponatremia, you should give hypertonic saline. Hyperkalemia, drug of choice is calcium gluconate, and the earliest is your fastest correction is can be done by insulin placed dextrose. The other treatment options are salbutamol, furosemide, then sodium polystyrene sulfonate, and then in refractory cases dialysis. Coming to your hyperphosphatemia, you need to give phosphate binding agents, that is calcium acetate, sevelamer hydrochloride, and aluminum hydroxide. And how do you treat hypocalcemia? That is calcium carbonate and calcium gluconate. Then Finally, you should know how to treat hypermagnesemia, that is by IV fluids and medications, loop diuretics. Hypertension can be treated by labetalol. Metabolic acidosis is being treated like when pH is less than 7.2 and bicarbonate is less than 10. Indications for dialysis have refractory hyperkalemia, refractory acidosis, volume overload, elevated blood urea nitrogen, pericarditis, uremic encephalopathy, and pulmonary edema. Okay, so this completes the discussion of your acute kidney injury, right? So we will have a lunch break now. We will reassemble and discuss the chronic renal failure and as well as renal replacement therapy. Okay, so we will just reassemble back. It is 1:10 now, so we will reassemble back again at 2 o'clock. Okay, right. Thank you very much. And if you have any doubts, you can just post it on a chat box. So I'll just go through your doubts and answer your doubts after the break. Okay, thank you.